We're back on the record before the Medical Board of California in the matter of the accusation against A. Grant Kingsbury. It's, MD, it's emergency case number 800-2017-038-069, OAH number 2020-010-011. This is the date, time, and place set for oral argument, and please notice hearing for oral argument. My name is Warren Wong. I'm an administrative law judge with the Office of Administrative Hearings. And for the record, if I could establish a quorum by taking roll, starting with Ms. Lubiano on my far right.
Lori Rose Lubiano here.
David Wormuth.
Ronald H. Lewis, MD.
Dr. Randy Hawkins.
Israel T.J. Watkins.
And let the record reflect that a quorum is present. And if I could take the appearance of the Deputy Attorney General, please.
Good morning, Keith Shaw for Complainant.
And sir, you're Dr. Kingsbury?
Yes.
Okay. The board in this matter has issued an order of non-adoption of proposed decision and has decided to determine the matter itself. So the board has invited the parties to present oral argument regarding whether the proposed penalty should be modified. The following process and time limitations will apply. Respondent will have 15 minutes to make an opening argument, and then the Deputy Attorney General will have 15 minutes for a response, followed by Respondent having 5 minutes for a closing argument, and then last, the Deputy Attorney General having 5 minutes for a closing. The time limits will be strictly enforced, and I'll remind the parties that argument should be based only on the existing record and shall not exceed the scope of the record of duly admitted evidence. No new evidence will be heard. The panel members may ask questions of the parties to clarify arguments, but may not ask questions that would elicit new evidence. And I or any of the panel members may ask a party to support a particular argument with a specific reference to the record. And then at the end of arguments by the parties, Dr. Kingsbury will have an opportunity to address the panel regarding the penalty. And if he chooses to exercise the penalty, I will place you under oath and then allow you to address the panel. And then after that, the board will adjourn to closed session to deliberate. A decision will not be issued today, but that will be issued at a later date. And then finally, just remind the parties that argument should be limited to what's in the record. So with that, Dr. Kingsbury.
Thank you very much. Can everybody hear me okay? Thank you so much for the opportunity to meet with you today. Thank you so much for letting me speak. I strongly believe in my case the discipline, in addition to the proposed disciplinary action order from the administrative law judge, is unnecessary to protect the public. 35 months of probation is more than adequate, offering the board a lengthy span of time for observation and monitoring. I understand probation is mandatory for the mismanagement of my client. I will be monitored for the duration of my probation and pay for the cost of monitoring myself. I will report all prescriptions for scheduled medications in a log, which can be audited by the board at any time. I have already completed UC San Diego PACE courses in record keeping, medical record keeping, and physician prescribing in early 2019 in anticipation of that requirement for my eventual discipline. I feel it's important for all of you to see who I really am as a clinician, and that this one difficult case does not define me. Who I really am is an internal medicine physician who sees 15 patients per day between the ages of 18 and 102. These patients are average age around 65 or so and have all kinds of cardiopulmonary problems, dementia, orthopedic situations, diabetes, various malignancies and rashes, etc., etc. Diet and healthy weight loss without medications is my main focus, as it has positive impact on nearly every other aspect of the medical problems that I treat. I'm also in the hospital treating serious illness and teaching residents and interns about the management of these often difficult cases. I have a unique breadth and depth of experience that I feel is valuable and demonstrates experience and competency. I have over 20 years in private practice. I have over 18 years at the teaching faculty at Scripps Mercy Hospital, a community-based hospital with a large indigent population, homeless people with mental illness, alcohol and drug dependence. I have 18 years in the Scripps Behavioral Health Unit, consulting on patients with medical problems superimposed on depression, anxiety, bipolar disorder, personality disorders, alcohol use disorders, and drug dependence. I've received many awards for patient satisfaction, outstanding recognition for my peers, colleagues, and students. I've been a member of my hospital's Physician Well-Being Committee for over 5 years, where we regularly review cases and look to support colleagues who are in trouble with the hospital's medical disciplinary committees, the medical board, or with law enforcement. In my clinical practice, very few of my patients require controlled substances, and only a handful require Schedule II medications on a regular basis. I'm not a pain specialist or an expert in addiction. Yet in 2011, I found myself entangled in an unhealthy dynamic with a manipulative patient who succeeded in getting higher volumes of controlled substances than I was aware. My poor documentation, my poor system for monitoring controlled substances was flawed. I could not accurately monitor the refills received. I was ignorant of the fact that a prescription of Vicodin for 180 pills intended to last 30 days could be refilled by a pharmacy in as little as 2 weeks, and that this was being done on a regular basis with this client. On one occasion, it was refilled after 6 days. I lost control of the controlled substances in this case, and for that I'm deeply remorseful. Please note, however, I did not willfully overprescribe Schedule III and IV controlled medications to him. It occurred mainly because my system was bad, my record keeping was worse. The right hand could not see what the left was doing. Recognizing the weaknesses in my system for prescribing controlled substances in 2013, 5 years prior to this investigation, I did the following. I required narcotic contracts for all patients requiring daily, regular use of narcotics. To these same patients, I provided detailed narcotic information packets. I required appointments, every other prescription for those clients needing these daily use prescriptions. I asked standardized questions, developed questions regarding quality and intensity of pain, degree of incapacitation, and also the degree of relief from the medications that I was prescribing. I inquired regularly about depression and suicidal thoughts. I'm constantly trying to reduce overall usage of controlled substances. I'm constantly exploring alternatives, therapies, pain modulators, which might further reduce scheduled medication use. I refer complicated cases to pain and palliative specialists. I perform the cures inquiries on a regular basis as required. Urine drug screening is now 1 to 2 times per year. I regularly use a very safe 2-factor electronic prescribing system for controlled substances from my office in the hospital, so there is no doubt that these prescriptions are for me and they are unmanipulated. Clearly, I mismanaged this case in 2011 to 2013, but I learned my lessons early on, and I took independent measures to correct the problems. I was burned severely, and I would not forget that. Today, with a new physician culture of prescribing, stricter standards and oversight, pharmacy partnerships, and all of my heightened awareness and internal safeguards, the events of this case will never be repeated in my practice. I'm a caring and thoughtful, cautious, and experienced teacher and practitioner of internal medicine who takes very good care of a challenging and elderly population of patients, counseling and educating, putting in long hours to make certain all are cared for and their health and safety are maintained. I am highly competent to safely practice my craft by virtue of these lessons, my detailed responses to my deficiencies, and my maintenance of certification from the American Board of Internal Medicine. I passed their 10-year recertification examination for the third time in October 2019. I am not a threat to public safety. I am a better physician than ever because of this case and all of my other experiences. I believe the board's requirement of a competency assessment is excessive and unnecessary to protect the safety of the public. I've proven my competency on a regular basis, as mentioned previously, and the American Board of Internal Medicine has found me worthy of board certification. In addition, I respectfully request no restriction on seeing clients in their places of residence. This has long been an important part of my practice, and my resource and mobility challenged patients need the service more and more. If I can practice solo in my office, I ought to be able to practice in the homes of my clients. Also, regarding my work in the hospital, I do not handle patients on my own anymore. I only see patients with the teaching service as a member of the teaching faculty. I respectfully request no formal recording and auditing on my hospital patients while hospitalized of their scheduled medications unless discharged with a controlled substance under my BPA. There are many attending physicians from many specialties, many residents as well, with prescribing powers, all moving in and out of the care of these same patients. And to sort mine out specifically would be virtually impossible. For example, when I assume care, attending responsibilities for 16 or 17 patients on Monday, several may be receiving scheduled medications prescribed by other physicians. The next week, when I release the service to another attending physician, they become the responsibility of another attending. It becomes very difficult to follow those prescriptions, and I ask for your understanding there. My understanding of these proceedings is that the Medical Board of California wishes above all to protect the public and to rehabilitate clinicians who remain potential threats to the public so that these mistakes are never made again. Please give me credit for all the positive changes I've made to my behaviors and practice in the 7 years since my mismanagement of this one case in 2013. No problems prior and none since. And the most robust changes I made were prior to the accusation or threat of discipline. It's been a long time, and I've learned a lot in that period of time. Once again, please accept the decision by the administrative law judge for 35 months probation with monitoring. Please remove the requirement for a core competency assessment in light of the depth and breadth of my experience, all of my efforts to rehabilitate my practice since 2013, and my passing of the American Board of Internal Medicine certification exam for the third decade, itself a test of competency in 2019. Thank you very much for the opportunity to speak with you today and share my thoughts.
Thank you. Mr. Shaw?
Thank you. Dr. Kingsbury's comments are appreciated, but I think the main primary focus of the board should be patient safety. And while this was a single patient case that did occur back between 2011 and 2013, the level of mismanagement is staggering. We had a patient here that, by Dr. Kingsbury's own words, he had no control over. This was a patient that Dr. Kingsbury began prescribing Vicodin in 2009, and by November 2011, it was made clear to Dr. Kingsbury that this patient was addicted to Vicodin, to this very medication, and that he was at toxic levels. A tapering plan was discussed with this patient at that time. However, there was absolutely no follow-through on Dr. Kingsbury's part. The patient remained taking and being prescribed high quantities of Vicodin during this time throughout 2012. In mid-2012, the patient, on his own accord, tried to quit cold turkey and experienced severe withdrawal symptoms. And then just several months later, there was a phone call to Dr. Kingsbury's office saying that he had lower back pain. And without even seeing this patient, and by knowing that this patient had taken such arduous measures to stop taking the medication he was addicted to, re-prescribed Vicodin again, and in extremely high quantities. And this continued through 2013 up until this patient's suicidal overdose in May of 2013. Just prior to May of 2013, at his last office visit, the patient described to Dr. Kingsbury that he was having suicidal thoughts, but he had no plan on following through at that time. Rather than immediately getting this patient help, Dr. Kingsbury prescribed him 240 tablets of Vicodin, an excessive amount, especially considering within the past 5 weeks, he had been prescribed 480 tablets of Vicodin. Knowing that this patient had suicidal ideation, giving him extremely high levels of the very drug that he was addicted to rose to such a high level of disregard for his safety, such a high level of incompetence. And this patient did in fact commit suicide, intentional overdose of a combination of medication, including Vicodin, including Xanax, and other medications that were being prescribed. Throughout the course of treatment of this patient, Dr. Kingsbury repeatedly ignored red flags. There were calls from pharmacists indicating early refills. The patient was clearly manipulating Dr. Kingsbury and would call in indicating that he had lost his medication, he had thrown up on his medication, he was going on vacation, so he needed early refills. So repeated requests for early refills were granted by Dr. Kingsbury over and over again. And by Dr. Kingsbury's own words, he was manipulated by this patient whose persistence wore him down. Dr. Kingsbury indicated that he did not demonstrate an ability to set limits and enforce rules, even though he was well aware of the dangers of the simultaneous prescription of opioids and benzodiazepines, which he was also prescribing to this patient. He did so without a clear diagnosis of this patient. There was a lack of informed consent. The documentation was grossly inadequate. And there was no treatment plan in place for this patient. As I discussed earlier, there was a plan to taper off that was never followed through. There was no treatment plan as to where this high opioid medication regimen was going and whether it was actually effective for this patient. The expert in this case summed up Dr. Kingsbury's conduct as a series of life-threatening extreme departures. And he stated that he had no control over this patient. Each and every accusation that was each and every allegation in the accusation was found to be proven at the hearing in this case, including numerous counts of gross negligence, repeated acts of negligence, failure to maintain adequate records, lack of knowledge, excessive prescribing, and prescribing without an appropriate physical examination. At the hearing, it was argued that the disciplinary guidelines should be followed in this case, given the extreme concern for patient safety. The ALJ proposed 35 months probation, with various terms and conditions, including maintaining records for controlled substances, education course, prescribing practice course, medical record keeping course, the clinical competence assessment program, practice monitor, and standard terms. And again, I would urge this panel to impose what's recommended in the disciplinary guidelines. Because even though time has passed in this case, the concern for patient safety has not been resolved. For there to be even one occasion where there was a single patient that can manipulate a doctor to that degree, and for the doctor to just hand out prescriptions for Vicodin knowing that that patient is addicted to that medication and clearly manipulating him is cause for great patient concern. So we would ask that the disciplinary guidelines be followed. Thank you.
Right, Dr. Kingsbury?
First of all, I would say that I disagree with Mr. Shaw's assessment that I did not follow through with any attempts to taper this patient. This happened on a couple of different occasions, and there were periods where he was on no narcotics for some time following this. He didn't. He makes it sound as if I had nothing to do with this patient's discontinuation or any control whatsoever, and that's not true. He did not act completely on his own to stop these medications. We had discussions. My problem was my documentation was terrible. It's not that I'm an abusive, uncaring physician. It is that I don't have the documentation to defend my actions at the time. Now, on this last visit, when he saw me on May 8th, 2013, the patient did not have a plan for suicide. On that day, I prescribed antidepressants. I referred to psychiatry urgently. Those records are in the chart. I'm concerned about the illusion of the medications present at the patient's death. He did not mention that clonazepam, an empty bottle of clonazepam, was at the scene. I did not prescribe clonazepam. Clonazepam was prescribed by another physician, a gastroenterologist that I know very well. He gave him 120 clonazepam, 0.5 milligrams, on May 14th, 6 days after I saw him on that last day. This bottle was empty at the scene. So I just want to make clear that he was clearly manipulating other physicians besides me. When I turned him down for Zolpidem, at one point there's record of an ear, nose, and throat doctor right below me prescribing Zolpidem the very next day. That's in the cures report. Give me one moment to find that. This is a prescription in the cures report dated May 25th, 2012. And there's record in my chart from the day before saying that I refused to prescribe him Zolpidem. On the last day that I saw him, there was a prescription for 240 Vicodin. I cannot prove to you definitely that I did not write that prescription, except for if you look at my records, every one of my records, all of my prescriptions for the last 8 months of his life were for much smaller quantities. They were spread over the appropriate amount of time. There was a couple of times where there was early refills, but I clearly had much more control over this person. My records indicate that I was prescribing 5 milligrams of Norco 5/500, 4 tablets a day, number 120. That's in my chart, all the way through all the notes up until this last day, including the last day. But the prescription was for 240 according to the cures report. Now, I cannot prove this. Please understand. I'm concerned that it was a paper prescription. I'm concerned that the number may have been altered. All my records show that I was prescribing 120 at a time and that I was advising 4 tablets a day. And on the last day, we talked about tapering his medication and to see him in 2 weeks.
Thank you, Mr. Shaw.
Thank you. Just, I will note that there's no indication at Dr. Kingsbury's subject interview that the prescription for 240 tablets of Vicodin may have been altered. That was first raised at the hearing in this matter. And again, I would ask that this board impose the disciplinary guidelines for excessive prescribing and for gross negligence, which would include a controlled substances restriction, either partial or full, an ethics course, which was not recommended, as well as prohibited practice. Thank you.
Okay, Dr. Kingsbury, do you wish to address the panel under oath regarding penalty?
I want to make sure I understand the question. Do you mean the way that the judgment came through already from the administrative law judge?
Well, it is something, it could potentially be redundant because you did argument, but generally doctors in your position are represented by counsel, and so it's just argument that counsel presented. In this case, since you're representing yourself, you presented your argument on your behalf, but you also, after argument, the doctor has a chance to address the panel regarding penalty under oath. So
Are you speaking of each and every component of the penalty?
well, whatever you believe the appropriate penalty is.
Thank you.
Okay, so if you do, then I need to place you under oath. So first, do you want to address the panel regarding that issue?
I'm not certain that I can speak completely.
And I don't, by asking you, I don't mean to imply that you're obligated to. I just did not want to deny you that opportunity just because you're representing yourself.
I think I've said what I need to say.
Okay, thank you. Are there any questions from the panel, starting with Ms. Viviano?
Just a clarifying question for Dr. Kingsbury.
Yes.
Can you repeat what you said about some of the steps you've taken with respect to prescriptions? You had mentioned specifically something about giving, you're allowed to double check.
Oh, yes. May I show you something? There's I have a little fob with me. It's one of these. It's a fob where I use my electronic medical record as eClinicalWorks. And when I have a box where I'm prescribing a controlled substance, I will click that I want to prescribe this amount, this refill or not. And then it will say insert code. And I will press this button one time, and a randomly generated code will appear here in front of me. I will type that in to the system, and then above that I will type in my identity code for my use of that EMR. Did that help?
Yes, thank you. No further questions.
No questions.
We'll just go down. I'll go ahead.
Activate your microphone.
Oh, yes. Thank you. said you've completed the recertification for the internal medicine boards, family practice board?
Yeah, the American Board of Internal Medicine has a 10-year recertification exam, which I passed in October of 2019.
In October of 2019, thank you. And in 2011, the case in question, I believe, with the one patient, or maybe a couple years before, prior to that, you said, we talked about documentation. What kind of documentation or EHR was in place at that time?
I had eClinical Works at that time, and I'm sorry, did you need more than that? I want to be clear for you.
Well, that's good. And also, did you tie in, or could you have tied into the hospital where some of these patients might have been seen by other physicians? Do they talk to each other where, besides cures, you would see patient charts that also you were in treatment plans with other physicians?
I'm a solo practitioner. I had my own electronic medical records for my own patients. The hospital had a completely different set. And so my communications were with the pharmacies back then.
Okay, so you were unable to see through the hospital's EHR what patients were being prescribed?
Yes. At that time, yes.
At that time, yes. And now?
Now the hospital uses Epic, and it's very easy to access that from my computer using a VPN, and I can dial in just a minute and see what's happening over there very easily. And
I just
did I
wanted
answer
to,
your question? I'm
yeah,
sorry.
I wanted to make sure there was another fail-safe now in place that you could see other patients that you may be treating with other physicians.
Honestly, the cure system is so good right now.
Yes.
That that's the easiest thing. I just do that every time.
Okay, that's good. And you do that with every
Yes.
new patient?
Well, but I almost start nobody on narcotics anymore, but with every new patient that I'm starting a new prescription on, I would definitely check your system for that.
Okay, thank you.
Thank you, Dr. Kingsbury. I may have misunderstood what you said, but in your introductory remarks, did you say you felt you were manipulated by the patient? If you said that, why did you say that?
This man was, I had known him for a long time. I'd started treating him, I think, in 2003. And I think, as Mr. Shaw said, I think I prescribed some of his first narcotic in 2009. And I think I just, he was a guy who was charming, intelligent, wanted to chat about a lot of different things, was emotionally vulnerable, I would say. And I tried my best to help him out. And I think I was far too concerned about his withdrawal. I was far too concerned about what's happening with him. In retrospect, I see that crystal clear. But at the moment when I was embroiled in that, I didn't. I was clearly not in control, and I did not have no control. I just didn't have enough control to make sure I knew what was happening.
Okay, Dr. Kingsbury. So my question is about before 2013. How did you feel about your record keeping, yourself as a doctor? Just give me an idea. How did you view yourself?
Well, it was, thank you for asking. I thought I was a good doctor. I thought I was well-trained. I was in the teaching faculty at that time almost 10 years. In 2012, I was in San Diego Magazine's top doctor category in internal medicine, elected by my peers, and as a solo practitioner, not somebody who's in a group of physicians that all vote for each other. I thought that was pretty cool. And I felt very good about myself. As far as my documentation, I would have to say that in retrospect, it's clear I was just trying to go quickly. I was not careful enough about what might happen in the future, like a situation like this. I was not seeing that. And I was not awake. I was not awake to that. And it took this situation to slap me across the face. It was a real eye-opener, and everything changed at that time for me. So I believe I was a good doctor. I believe I was a terrible documentarian. And I think since then, I've gotten much better. I feel that I'm a very good physician right now.
And at the time, you actually felt that you were a good doctor, maybe some documentation issues, but there was a blind spot.
Yes.
Right? And while you thought you were a great doctor, a patient died under your care.
Well, patients always die throughout my practice, right? They die of all kinds of different things. So I understand that he committed suicide and some of the medication that he took was the ones that I prescribed. I understand that. I took that very personally. And at the same time, I'm working in the psychiatric unit and I'm seeing patients with all these same problems who are trying to push and pull all the time. To me, at the time, it feels to me that I'm actually in the thick of things on the front lines. I should be able to deal with this, and yet this happened. And I understand that. I just, it's so humbling, I can't possibly describe the feeling.
And that's interesting that you say humbling, because at the same time you recommend from your end of it self-probation pretty much. I don't want to do this because the American board has made me a better doctor, essentially is what you're saying. And you can correct me at any time.
I just want to let you know that I agree with the 35 months of probation. I don't want to tell you that probation is not necessary. Please don't misunderstand me.
Well, you don't agree with the conditions of it because you feel like you are beyond that.
Well, when you say it, it sounds different, you know?
Well, because it's meant to sound different.
It's, but I feel that I'm very competent, and I'm not the only one who feels that. I received that feedback from a lot of different entities and people.
And yet you had that same feedback because you were working in psychiatric, with psychiatric patients, and you thought you had that. As per what you just said a few minutes. So there was a blind spot.
Absolutely, sir.
If we can speak one at a time, please.
So my question is, your self-probation, I can only describe it as self-probation because you can articulate it so clearly. But that's not board probation, because you can feel very confident in yourself that you are capable of it. And so the conditions that even was imposed in the proposed decision, that you say, we don't want, that doesn't apply to me, that doesn't apply to me. Is it possible that those conditions could highlight some of the blind spot that is right now present? Or do you feel, well, it's just that course, and I've seen that 1,000 times, I've spoken to 2 people that done that.
Well, I'll tell you that I'm humbled every day, and I have a lot to learn. And there's no way that I feel that I know everything and that I'm beyond reproach. I understand that I'm a human and I'm dealing with other humans, and that mistakes can be made, and mistakes were made. And I'm trying to say that I'm the best physician that I've ever been, and I'm so much better than I was back in 2013. And so, while I understand that there are mandatory aspects of my discipline, I'm appealing to you to give me credit, to respect what I've already been through and what I've already accomplished, and apply that towards the discipline.
Thank you.
I have a question for Mr. Shaw. Mr. Shaw, you mentioned about accepting the ALJ's recommendation, which includes PACE, correct?
Correct.
Oh. Do you know the difference in the competency review in PACE versus passing the recertification examination by the American Board of Internal Medicine? Yes, ma'am.
No, I'm familiar with the requirements of PACE. The requirements for the American Board of Internal Medicine, to my cursory knowledge, are different. PACE will do a thorough and detailed evaluation of Dr. Kingsbury to ensure that he is fit to practice medicine safely. And there's 6 core competency areas that they will evaluate him in. And at the end of that evaluation, there'll be a proposal to the board whether he is safe to practice medicine. So my familiarity with PACE is that it's an excellent program, an excellent evaluation of doctors, specifically in these type of scenarios where patient safety is an issue, to determine and to evaluate their ongoing care of patients.
And are you aware that we use PACE many times in these panel discussions or in recommending probationary terms for physicians who have been away from practice for a period of time, even except for the psychological component and physical examination?
Yes, I am aware of that.
Okay, that's all I wanted to clarify from you. Thank you. No questions?
Okay, are there any further questions from the panel?
No.
Seeing none, this concludes arguments in this matter. The record's closed, the case is submitted, and we're off the record.